For the next oral presentation before lunch, entitled Malautonomous Cortisol Secretion in Adrenal Incidentalomas associated with greater burden of coronary artery and atherosclerotic cardiovascular disease, presented by Napatsawan Reawreab from Faculty of Medicine, Prince of Songkla University.
Good morning, everyone. I am Napatsawan Reawreab, a fourth-year medical student from Prince of Songkla University. Today, I'm honored to present our study, Malautonomous Cortisol Secretion in Adrenal Incidentalomas associated with greater burdens of coronary artery and atherosclerotic cardiovascular disease. Adrenal incidentalomas is adrenal mass accidentally discovered during diagnosis for other conditions and found up 3% in general population. From the etiology of this tumor, the majority is non-functioning adrenal adenoma or NFAT, followed by 20% of malautonomous cortisol secretions or MACs, and both groups lack of clinical manifestations. Nowadays, we lack of definitive treatments for MACs. We only treat the associated complications such as diabetes and hypertension. As we know, chronic cortisol excess typically present with the classic features of Cushing syndrome. Importantly, the hypercortisolism diet more complications such as diabetes, hypertension, coronary artery disease, and osteoporosis. All of this we know for NCD. Up to the point, we have focused on overt hypercortisolism. However, many our adrenal incidentaloma patients sit in the middle zones, malautonomous cortisol secretions or MACs. They often look completely well but have a burden of metabolic complications. To evaluate cortisol excess of these tumors, the gold standard is the 1 mg dexamethasone suppression test to measure cortisol levels. Normally, cortisol suppresses after the 1 mg dexamethasone suppression test in adrenal tumor we call NFAT. Classically, Cushing syndrome cortisol more than 1.8 microgram per deciliter. However, there is another group we call MACs who show no clinical signs of hypercortisolism but still have non-suppressible cortisols. This indicates that without obvious symptoms of MACs may still exert functional effects. This current knowledge gap in Thailand is unclear relationship between MACs and cardiovascular or metabolic complications. If we can clarify these associations, may support early interventions or definitive adrenalectomies to reduce long-term complications. Lead to our primary objective to evaluate metabolic complications between NFAT and MACs in patients with adrenal incidentalomas. However, we hypothesize that cortisol excess is acute or continuous at spectrums, leading to secondary objective to evaluate the correlations between cortisol levels after 1 mg dexamethasone suppression test in metabolic complications. Study design is retrospective cross-sectional studies in Songkla hospitals in patients who underwent CT imaging and compare clinical outcome in MACs group and NFAT. We started with the adrenal tumor populations. First, we acute malignancies and tumor-producing other hormones. Then we using the cortisol levels after 1 mg dexamethasone suppression test with a cut of 1.8 microgram per deciliter. We stratify the patient into two groups, NFAT and MACs. Then we compare those groups across metabolic complications, cardiovascular, and bone health outcomes, and analyzes the data, use chi-square, t-test, and Pearson correlation for cortisol levels. And this primary objective, we need 205 for simple size. For metabolic complications, we assess variables including HbA1c, blood pressures, and lipid profiles. To ensure accuracy, we collected data within plus or minus 3 months of 1 mg dexamethasone suppression test. The baseline characteristics in the two groups were comparable, except for BMI, which was lower than in the MAC groups. In MACs patients, studies have shown a higher prevalence of dyslipidemia compared to NFAT. And we found the trend toward higher of diabetes, coronary artery disease, and atherosclerosis in MAC, but the p-value not significant. Regarding dyslipidemia, we found no correlations as shown by the flat line. For diabetes and hypertension, we observe a positive trends, although no statistic significant. The data might see the potential clinical link. Our findings are consistent with global data of metabolic risk of MACs. We observe significantly higher rates of dyslipidemias in MAC patients, along with trend towards diabetes, coronary artery disease, and atherosclerosis. Because this is a retrospective cross-sectional study with preliminary data from only 145 patients, we plan to explain the sample size as a conduct longitudinal follow-up to better clarify this association. Interestingly, MAX patients in our study had low BMI. This unexpected finding highlights as potential underlying disease mechanism that warrant future investigation. In the conclusion, in this study, we observed a trend towards more coronary artery disease and atherosclerosis risk factors. Many MAX patients presented with a non-obese phenotype, so BMI alone may not reflect their underlying metabolic burden. Therefore, in our patients with metabolic complications, we must actively screen to treat the root of cause and prevent future morbidities. Thank you for your attention.
Such a well-articulated and important topic, we now proceed with the question and answer session from the judges.
So this is preliminary data, right?
Yes.
So because the sample size that you plan is 200 plus.
In fact, yes.
So the results show that the CAD and ASCVD was significant higher, but when you do the multivariate analysis, it's not significant.
For this is preliminary results. So in this study, we only analyze just a univariate, and we have to enter analysis for multivariable because of we know that NCD is a multi-factor can cause. So in the future, we have to do multivariable.
So in your slide that you show, you have already studied the bone quality between these two groups. What is the result of the study? Did you do the BMD?
We use the T-score from the DEXA scan. So this is our result. So the we use to the osteoporosis. For the true group is not different because not every patient have to do the bone scan. So the data we missing, and we plan to do this in a perspective to recall the patients and do it. Yeah.
So this is a retrospective study, right? So actually at the time that you are correcting the cortisol, is that the time that you correct all this characteristic, or is it like how many years apart?
For the lab value that we plot the patient, we use plus minus 3 months of 1 milligram dexamethasone cortisol level, but the prevalence of disease like the dyslipidemia we use for long whole life since diagnosis, because we doesn't know that mass is become before disease or disease become before max. So, and we use the since the diagnosis, except the lab value that we use the time cost.
Well, thank you once again. Give her a round of applause.
Thank you.